Good morning everybody. I am Professor Dr. P.V. Ramachandran, Clinical Professor of Radiology at Amrita Institute of Medical Sciences. We are just discussing the role of radiology in diffuse parenchymal lung disease. If you look back the history till about 1996, we were just looking at chest X-rays and images of single slice CT and trying to derive some conclusions. But all these things drastically changed with the advent of HRCT and two sets of classifications. Originally what happened is in 2011 there was an international multidisciplinary consensus classification which resulted in a joint statement by American Thoracic Society and European Respiratory Society. The whole issue was revisited in 2011, and between 2011 and 2013 two more joint statements came, this time more people getting involved. For example, the Japanese Respiratory Society and the Association of Latin American Thoracic Societies also were involved. So let us look at the evolution of chest CT before any of these things. In 1971, as you know, the first clinical testing of CT happened at Kingston Morley Hospital at Hounsfield. At that time, even a head scan, even a single slice required 4 to 5 minutes, so only head could be scanned. It was not until 1974 body scan became possible, because when a body scanner was obtained at Cleveland, Mellingtrot and Mayo hospitals. But even then people were pessimistic on thorax as that needed breath holding. So it is only in 1977 when Johns Hopkins got CT that chest CT became possible for the first time. The two big names, as you know now, Naidich and Cerrone, at those time were residents of the Professor Siegelman. And in 80, Naidich went to New York and Cerrone went to East Virginia. And in 82, 83, both went round in different parts of Europe giving instructional courses in chest CT. And it was only in 1984 first edition of CT and MRI of thorax by them came. Now what we have is an updated edition of 2013, which is actually the fourth edition of 2006. The first edition of HRCT of lung by Webb and Nestor Muller came in 1992, which has now reached the sixth edition in 2015. I said before that we used to say something about diffuse parenchymal lung disease. We were just commenting on chest X-rays and trying to say that this is extrinsic allergic alveolitis, this is cryptogenic fibrosing alveolitis, etc. The father of chest rhongenology, Felsen, has commented like this: after many years of trying and testing, I have convinced myself that certain patterns of diffuse pulmonary shadows can be distinguished in most patients. Nevertheless, I have had considerable difficulty in teaching others how to do it. Next sentence is more interesting. In fact, a number of respected colleagues who also claim success in pattern recognition often differ with me when viewing the same films. Others even feel that the pattern approach is so unreliable. He said, why is it that? See, that is people who are claiming to be experts who are not agreeing in their interpretation of chest films. He himself answered the question. He said, inconsistent terminology and certain misconceptions in respect to pathological alterations are responsible for many of the difficulties. So, anatomy and terminology are very important. Even before that, what is the essential advantage of HRCT compared to CT? CT gives you visual examination of the lungs unimpaired by chest wall, heart or pulmonary vessels. Normally you know that when you do a chest X-ray, you have hardly 40% of lungs available for viewing. So that disadvantage is removed by normal CT. But coming to HRCT, it sees down to the level of secondary pulmonary lobule, which is the building block of lung. So, and moreover, since they are thin section, superimposition of structures in 2D images is reduced, and you also employ a very high spatial reconstruction algorithm with the enhancement of the edge. So that is what is being done in HRCT. So going to the anatomy, secondary pulmonary lobule is the smallest imageable lung unit. You can't image less than that. Each is a polyhedral structure with 1 to 2 1 to 2.5 centimeter measurement on each side, and there is an interlobular septa, lobular core and the lobular parenchyma. If you look at this picture, you can see that the artery is accompanied by a bronchiole which goes into the center of that lobule, whereas veins traverse through the septa along with lymphatics. Look at this picture. Actually, a lobule is composed of several acinas, some 5 to 20 acinae are there in one secondary pulmonary lobule. In fact, you speak about acinar nodules when you speak about tuberculosis, etc. So this is a bigger unit called a secondary pulmonary lobule. You can see the vein passing through the septa. You can see the artery and the bronchiole ending in the core region of the secondary pulmonary lobule. Looking at the low power photomicrograph, again if you see, you can see the alveoli and the adjacent artery and the bronchiole. See, and you see a space in between. That is, an artery is identifiable by its thick muscular wall, the accompanying bronchus containing some mucoid material, and which is lined by a columnar respiratory epithelium. So the vessel has got an endothelium and the alveolus has got an epithelium. So between these two is the place where the diffuse lung parenchymal disease is occurring. This is a radiograph of a slice of lung. You can again see the artery is being accompanied by the airway branch, whereas the vein is passing through the septa. So that means in a radiograph you will be seeing the bronchi and arteries contained within a connective tissue sheath, which is termed the peribronchovascular interstitial. And pulmonary arteries usually divide into two branches of similar size, whereas pulmonary veins give rise to numerous small branches arising at right angles. Look at this one. The arrowed ones are arterial branches which just divide. But you look at the what you see in the upper part, that is anterior part on left side, you can see branches arising from a single structure. So that is vein. So that's how you differentiate between vein and artery in a radiograph. But the problem is the findings on which you try to make the interpretations are numerous like this, and they are scattered everywhere in the lungs. For example, you can see honeycombing adjacent to the pleural margin. When I say pleural margin, the subpleural region is not only in the costal subpleural region. Subpleural region can also be beneath the diaphragm, and also it can be adjacent to the mediastinal surface, and also along the pleural surfaces, that is fissures also. So it can be fissural or costal or mediastinal subpleural interstitium where you see the honeycombing. And you can see branching structures which we describe as tree bud lesions. You can see the bronchus dilated compared to the adjacent vessel, which is due to the traction bronchiectasis, which if you are cutting it across, you see it as a signet ring sign, as you see in the lower posterior medial part. Then there are something called subpleural lines, which are just lines parallel to the surface, and you also get long shadows called intralobular lines, that is when the reticulations are occurring. So to make it very simple, the word reticular corresponds to lines and the nodular corresponds to dots, and high attenuation means white and low attenuation means black. So this is very fundamental of that. And another basic interpretation is regarding the distribution of lesions. You should look at the location in the secondary pulmonary lobule. You should differentiate between upper and lower, and central versus peripheral. So these are only the things which you look at, whether they are lines or dots, whether they are areas are white or black, and also whether they are located in the secondary pulmonary lobule or somewhere else, or whether they are related to upper or lower parts. And what was happening before the advent of HRCT? The CT request used to be something like this: cough, dyspnea, no or poor response, not to treatment, ILD. Before HRCT, the report also was like this: reticulonodular shadowing, ground glass opacities, probably ILD. That was how we used to report that. But this is another problem. When you speak about the findings are not strictly allocated to what you call different diseases. They just overlap. For example, you can get septal thickening in different diseases, you can get nodules in different diseases, you can get cystic sphere spaces and honeycombing in different diseases, ground glass attenuation you find in most of them, then how do you go about the whole thing? That is where the HRCT comes. So, if you look at what is happening in HRCT, if you look carefully, you can see that on the right side it is a 5 millimeter thick thing. So, what happens is the appearance is it is just cutting through the middle of that one. So, you will not get a sharp edge, the edges are irregular, whereas in HRCT you are taking a very thin section. So, it is going to be very sharp. I will explain it further. Compare these two pictures. With a 5 millimeter one, you think there are a lot of disease, you find it looks something like a ground glass pattern, and what do you call it, even the vessels are very irregular. You do not know whether any lesion is there in the hilar region, but when you do the 1 mm thing, you find that what appeared so complex in the 5 mm section is only a simple linear plate atelectasis, nothing else is happening there. And this is, for example, thus an example of a false positive. Now, let us come to another situation. Are you seeing anything here? If you look carefully, on the right one, on the right side, you might suspect something vaguely in the midsole, isn't it? But look at the single one. See, so much contrast, so much difference occurs when the images come from 5 millimeter to 1 millimeter. So, this is an example of a false negative one. And also look at these pictures, 10 mm, not very clear, 5 mm, 2 mm or 1 mm. While 1 mm you are identifying the ground glass pattern much better, or look at this one. So, reticular pattern, and again there are problems with the reticular pattern also. Sometimes reticular patterns are not very simple. You will not be able to differentiate between a honeycombing or a traction bronchiectasis or even a small emphysematous area which is bordered by lines. Look at this one, it is 10 mm, it is very vague and unclear. 5 mm it became much clearer, 2 mm still clearer, 3 mm. See, 1 mm it is very sharp. Looking at 1 mm, now you know that what you see anteriorly is a small segment of traction bronchiectasis. Similarly, right, the posterior part also, that is traction bronchiectasis. Similarly, you identify a few areas of honeycombing posteriorly. So, this is the value of HRCT. Now, let us look at the terminology. The terminologies have been very complex over last several years. Initially, the great people Neidich, Serrani and Siegelman themselves used the word called chronic infiltrative lung disease. They did not, in their description, I referred to infiltrative, not interstitial. The reason is they rightly observed that many diseases were involving air spaces also, that is bronchial airways and air spaces also. So, you cannot simply call it interstitium. Interstitium is the area between the alveolar epithelium and the vascular endothelium. So, they just used the word chronic infiltrative lung disease, but there is a problem. All diseases are not chronic. There are entities like acute interstitial pneumonia, there are entities like cryptogenic organizing pneumonia. Then this is probably a better terminology which we even now follow when we talk about that. This is used by Martin Remy Jardin, a very significant person regarding the history of interstitial lung diseases all over the world. She gives talks and she has got several textbooks and hundreds of publications to her credit which describes all these details. So, she always uses the word diffuse parenchymal lung disease. It can be interstitial or alveolar. Then sometimes people have used words like this also. This is what you find in Sutton, non-neoplastic parenchymal lung disease. Again there is a problem. The previously known bronchiolar cell carcinoma, of course we now call it as adenocarcinoma, and lymphangitis carcinomatosa are obviously neoplastic, and if a case of lymphangitis carcinomatosis comes in between, you may have difficulty in differentiating between a idiopathic interstitial pneumonia. Anyway, so the terminologies have been changing from ILD to CILD, diffuse interstitial lung disease, diffuse parenchymal lung disease, non-neoplastic parenchymal lung disease, and then in 2002 the word came idiopathic interstitial pneumonias, which is a group about which we are going to talk a bit detail a bit later. And also between 2011 and 2013, more clarity appeared regarding the most important disease amongst it called idiopathic pulmonary fibrosis as well as idiopathic non-specific interstitial pneumonia. So, now we are going to speak about a group of diseases which are called idiopathic interstitial pneumonias. We have a collection of radiographs belonging to each of these diseases in the department, which we can discuss later. Now, just listen to this one. So, this particular group, they are different and distinct diseases, but rare, and reaching correct diagnosis is always a dynamic process, and there is a definite set of histologic patterns for each of them. And HRCT and surgical lung biopsy are important, and integrated approach is required. That is why we need all this. And what is to summarize again, what is idiopathic interstitial pneumonia? They are a heterogeneous group of non-neoplastic disorders resulting from damage to lung parenchyma by varying patterns of inflammation and fibrosis. The interstitium includes, as I said earlier, the space between the epithelial and endothelial basement membrane, and that is the primary site of injury. However, these disorders frequently affect not only the interstitium, but also the air spaces, peripheral airways. Because of the fibrosis, they apply traction on the bronchial walls, and hence the traction bronchiectasis. And the problem is the pathologists always divide these things very easily because they have a different pathological appearance. So, they have no confusion in differentiating idiopathic interstitial pneumonia from non-specific interstitial pneumonia. But the clinicians, generally the pathologists are called splitters and clinicians are called lumpers, because the clinicians tend to apply a single term that included several different pathological patterns. For example, the term IPF is a very specific entity, but the pathological pattern of IPF called UIP is there also in collagen diseases and sometimes drug induced varieties, or even associated with hypersensitivity pneumonias. So, a teamwork is very important with interaction between the clinician, radiologist and pathologist to reach a correct diagnosis. I do not want you to look at this slide, this particular slide at all, because even before HRCT or even before CT, we used to have classifications. As early as in 1969, we had classifications because the pathology is there at that time also. But all these things went on changing, groups joining each other, and 1997 it was modified. But after this 2002 classification, we are very clear of what we are talking about. So, the clinico-pathologic entities which are included in the order of the frequency of occurrence are as follows. This is after excluding diseases like collagen diseases. For example, collagen disease associated lung disease, previously called extrinsic allergic alveolitis, that is things which we now call chronic hypersensitivity pneumonia, and drug induced diseases. If you separate out all these things, then again a group remains which are essentially idiopathic and hence called idiopathic interstitial pneumonia. Out of this, the commonest one is idiopathic pulmonary fibrosis, followed by non-specific interstitial pneumonia or NSIP, cryptogenic organizing pneumonia or COP, acute interstitial pneumonia, respiratory bronchiolitis associated interstitial lung disease, desquamative interstitial pneumonia, and lymphoid interstitial pneumonia. Please remember that these classifications have changed a bit after the 2011 conference, which I will talk on the whole thing on another day. Before that, you should be knowing what happened in 2002. That is only a rearrangement and addition of just one entity which happened in 2013. So, we are now confining ourselves to the 2002 classification. Note that even at that time, all these have an essentially a histologic pattern behind it. For example, IPF, what was previously called CFA, that is cryptogenic fibrosing alveolitis, cause is not known. There is a pattern of usual interstitial pneumonia. NSIP, the pathological and histological and clinical terms are same. It is not provisional anymore, it is a specific entity, and they have a histologic pattern of non-specific interstitial pneumonia. What you call COP or BOOP, cryptogenic organizing pneumonia, has got a pattern called OP or organizing pneumonia. And acute interstitial pneumonia has got a pattern of diffuse alveolar damage or DAD. And both the smoking induced lung diseases have got a pattern of respiratory bronchiolitis. They are now together called alveolar macrophage pneumonia because you find smokers, pigment and macrophages in alveoli. The last is rare one is lymphoid interstitial pneumonia. So, the role of HRCT is In more than 50% cases of suspected to be IPF, the presence of typical clinical and HRCT features when identified by expert clinicians and radiologists is sufficiently characteristic to allow a confident diagnosis and eliminate the need for biopsy. These things have been further clarified and made clearer in the 2013 classification, which we will discuss on another day. HRCT may also provide clues to the non-IIP diseases. This is important. When you talk about idiopathic pulmonary fibrosis or any of these groups, individual members of the idiopathic interstitial pneumonias, you are essentially excluding the other lesions for which the volumetric acquisition of images help. Even though you are talking about a thin section HRCT, nowadays the thin section of HRCT is taken not in a stop move technique. Previously we used to take 1 mm section, patient moves, again 1 mm, patient moves, again 1 mm. Now it is not like that. Actually we are acquiring the whole thing as a volume after the advent of MDCT, and from that volume we are reconstructing 1 mm sections. So that is what now being done. So yes, especially the volume one, which encompasses the whole information, are very helpful in straight away diagnosing entities like sarcoidosis and some of the very typical ones like pulmonary alveolar proteinosis, or it is even able to separate entities like histiocytosis, that is Langermann cell histiocytosis, and even lymphangiomyomatosis. So you are able to exclude all those diseases also before coming to the idiopathic interstitial pneumonias. Looking at this one, so just repeat what I have just said now. You have DPLD of known cause, that is drugs or those associated with the collagen vascular diseases. And go to the third one, you have granulomatous DPLD, classical example is sarcoidosis, and you have rarer entities like histiocytosis, pulmonary alveolar proteinosis, lymphangiomyomatosis, etc. Then remains a group called idiopathic interstitial pneumonias. In that idiopathic interstitial pneumonias, a characteristically distinguishable one is idiopathic pulmonary fibrosis with proper history and proper HRCT appearances. You do not even need a surgical lung biopsy, but the other 6 might need biopsy or might not need, but depending upon how specific are the appearances. So idiopathic pulmonary fibrosis stands out as a separate entity, but the other 6 are there. So look at it again: history, physical examination, chest radiograph, lung function tests. You know certain things are not IIP, that is collagen vascular disease, drug, environment, etc. Then comes possible idiopathic interstitial pneumonias. Then do HRCT. At the extreme left you see confident CT diagnosis of IPF with consistent clinical features, then atypical features, then suspect other DPLD. These things I will stop here because it has been further made easy in the new classification of 2013. Let us also have a look at what was happening before the advent of HRCT. Not that we were not diagnosing these diseases, but the emphasis was mainly on clinical. For example, this was a chest X-ray of a patient with a progressive systemic sclerosis. Actually, most of these lesions, progressive systemic sclerosis, rheumatoid arthritis, polymyositis, systemic lupus erythematosus, mixed collective tissue disorder, all these gives a UIP appearance. But they were typically less aggressive, occurring in a slightly younger age group, with the exception that pleural involvement is much more common with rheumatoid arthritis. In other words, you are giving more stress to the clinical features. Look at PSS, that is scleroderma alone. The chest X-ray is abnormal in 65% of cases. Even a conventional CT was abnormal in 90 to 91%. Of course, HRCT will show you better the appearance of reticulations, ground glass attenuation. But before this is the way we used to look at you can just suggest that some shadowing are there with basal predominance, and there are other clues. For example, the esophagus is dilated, so you expect that in scleroderma. So this is how we used to try to gather the information in conventional CT. But coming to HRCT, see, things are very sharp. You can see that there is a predominance in the basal regions, and there is fibrosis, there are reticular lines, and probably there is a bit of traction bronchiectasis also. So this is how it improved from conventional CT to HRCT. Just have a look at hypersensitivity pneumonia also, or called extrinsic allergic alveolitis. Just to refresh your memory, this has got a list of some 250 diseases that is exposure to various antigens, especially bird fanciers disease and various chemicals and all those things. But basically they are divided into 3 types. You have no problem in diagnosing an acute case because it is a febrile illness with the consolidations, etc. But the subacute and chronic ones are problems. Subacute ones will have a reticulonodular pattern with ground glass opacity, whereas chronic ones will have fibrosis affecting all the zones. In fact, the relative sparing of lung bases and the relative predominance in upper zones is the only clue to differentiate from UIP sometimes. So, this is an old case which we have published at some point of time. This is hypersensitivity pneumonitis. It is in a 11-year-old school girl who developed the illness following in school arts festival the next day. So, she got it from the hair, and you can see it is treatable disease. Before and after treatment, see the appearance of that particular case. So, I am not going to the range of occupational exposures and the predictors of hypersensitivity pneumonia, since they do not form our today's topic. This is another typical disease with a CT you will diagnose. What is that? If you look carefully, you will see that there is background ground glass haziness, and if you look still carefully, you get something called it looks at you what is called a crazy pavement appearance, that is a background ground glass haziness and interlobular septal thickening. This is not exclusive for pulmonary alveolar proteinosis. This is of course a classic case of pulmonary alveolar proteinosis with a geographical pattern, etc. But you can get this also in PCP pneumonias and sometimes even in cryptogenic organizing pneumonia. It only needs 2 entities. One is ground glass opacity in the background, second is interlobular septal thickening. And this is by particular case again chest X-ray and disease. And just to give 2 more examples, that is Langerhans cell histiocytosis, which has got changes confined to lungs in 60% of cases, and they are the clinical features I have just enumerated there. And here one point is there is no loss of volume, whereas normally in idiopathic interstitial pneumonias, especially in IPF, you find a loss of volume except in emphysema. But here these are young patients and there is no loss of volume, and you will get small nodules, and the nodules later on cavitate and you get cysts. It has got a characteristic appearance. Another one is silicosis and Kohlwerker's pneumoconiosis. If you look carefully, they are very, very subtle powdery substances, but it also develop what is called progressive massive fibrosis, and they can even develop cancers later on. Asbestosis. You are familiar with the pleural plaques of asbestosis. I am not talking about that, I am talking about the asbestos induced lung disease, which is very subtle. Probably that is the only instance when you will have to do prone images also. See, as you know, it is very familiar, you are very familiar with the appearance of basal dependent densities. So, once you do a prone image, that will disappear. Coming back to the ATSIERS classification of 2002, we are coming to the important point of idiopathic pulmonary fibrosis. Once again, we summarize the classical findings. There is a distinct type of chronic fibrosing interstitial pneumonia of unknown cause limited to lungs, associated with a surgical lung biopsy showing histological pattern of UIP. So, as I said earlier, it needs exclusion of other known causes of disease like drug toxicity, environmental exposure, collagen vascular disease, and it has characteristic abnormalities on HRCT and characteristic pulmonary function test abnormalities too. And what are the findings? Predominantly subpleural bibasal reticular pattern. The lesions are confined to the subpleural regions with a predominance in lower zones, but there can be lesions also in the upper part, especially in the upper zones. It can ascend through the sides also, and you can see the lesions wherever there is a subpleural interstitium, which means not only at the periphery but also along the mediastinal surface, along the diaphragmatic surface, and also wherever there are fissures, fissural subpleural interstitium, and altogether there is a reduced lung volume. As I said, only caution is emphysema. And the key word or in the IPF is what is called temporal heterogeneity. The word temporal, the word meaning, it refers to time, images over a period of time. That is, it is, see, you can just say heterogeneous if there are different lesions in lungs. When we say temporal heterogeneity, what we are meaning is the lesions have occurred at different times. For example, in the same picture, same image, you see normal areas, subtle ground glass opacity, linear reticulations and end stage honeycombing. So, the lesions have occurred at different times and all are seen at the same time in a single time image. Honeycombing and traction bronchiectasis are very important. Sometimes you even identify traction bronchiolectasis. And there is another entity called accelerated IPF or an acute exacerbation of IPF, which will have a histological pattern of not UIP, but a super added diffuse alveolar damage too, which will have extensive ground glass opacity. Otherwise, ground glass opacity is not a predominant feature, even though it can occur occasionally, in which case they represent either subtle fibrosis, that is, when you see ground glass opacity in idiopathic pulmonary fibrosis, they do not necessarily indicate active inflammation, though it can. Even fibrosis, which is below the level of HRCT to recognize, that is very subtle fibrosis, will show you as a ground glass opacity. That is why we say ground glass opacity is not the hallmark of IPF. The hallmark of IPF is temporal heterogeneity and honeycombing. Anyway, these things have been further clarified in the 2013 classification. This is just to show you a typical case. Another thing, this is part of old classification. We have now dispensed with this major criteria and minor criteria, etc. Even though some of them are important. For example, age is still important. You don't get IPF in a 30-year-old, 40-year-old person. It is a disease of older age group, 50 or even above 60. But you cannot say that it is always insidious onset. Sometimes the patient can first present with an acute exacerbation of an IPF. So the history of 3 months or 6 months is no more relevant. In other words, these major criteria and minor criteria have been discarded in the second classification, so we are not looking at it. But look at the pictures, very characteristic pictures. Normally the honeycombing are very small lesions, 1 to 2 centimeter. I mean, few millimeters, 5 millimeter, etc., where a septum is common for 2 adjacent honeycombs, just like the honeycomb, but occasionally a single lesion can be as big as 2 to 2.5 centimeter as you see here. But again, look at it carefully, you see normal areas in between. If you concentrate on the mid zone, in the region of mid lung window in the right hemithorax, you see an apparently normal lung. So that appearance you will get only in UIP pattern of IPF. See, look at it again, there are quite normal areas in between, but at the same time extensive subpleural disease, there is traction bronchiectasis, there is honeycombing. And what are the clinical conditions associated with the UIP pattern? Of course, the most important is idiopathic pulmonary fibrosis. Then, as we said earlier, collagen vascular disease, drug toxicity, even chronic hypersensitivity pneumonitis, asbestosis, familial idiopathic pulmonary fibrosis, which is now a well-known entity, and also a syndrome of Hermansky-Pudalk syndrome. And what are the associations of IPF? See, IPF is a very important, very significant disease all over the world. What are its associations? It has been now proved that it has got an increased risk of lung cancer. It also has got an increased risk of tuberculosis, and it paves the way for opportunistic infections, particularly Pneumocystis jirovecii, that is what you call PCP. You might notice that originally the terminology PCP came for Pneumocystis carinii pneumonia. The C used to refer to carinii, but now you know that the pathogen is different. Pathogen is not Pneumocystis carinii, it is jirovecii. So, but just to retain the old eponym, we still call it PCP, but which just means Pneumocystis pneumonia. And IPF can have an acute respiratory worsening, which may be secondary to pneumonia, pulmonary embolism, pneumothorax or cardiac failure. We name it an acute exacerbation of IPF or an accelerated IPF only if no cause can be found. See, this is a case of a mass lesion. In a case of quite rather early IPF, you can only see subtle features of usual interstitial pneumonia. And also, when malignancy superimposes in a case of idiopathic pulmonary fibrosis, it is very difficult to differentiate in the chest X-ray. Normally, you find you report even small lesions in chest X-rays and subject it to CT. See, for example, even during a comprehensive checkup, if you find a chest X-ray small lesion, it needs further evaluation. But here, you are not suspecting anything. But it is a known case of idiopathic pulmonary fibrosis. See what happened between 3 months of waiting for a lesion. That lesion is not even, same chest X-ray, that lesion is not even discernible in the chest X-ray. but it was quite small. So, you should have picked up that is a quite an irregular lesion, mass lesion probably, and it proved to be one. Then comes non-specific interstitial pneumonia, the second commonest entity. This is characterized by a particular type of a homogeneous expansion of alveolar walls by interstitial inflammation and fibrosis. And there are three major subgroups in non-specific interstitial pneumonia. One is primarily with inflammation, which is called cellular NSIP. The other extreme is primarily with fibrosis, which is called fibrotic NSIP, and an in-between group with both inflammation and fibrosis. So, 40% of cases have associated collagen diseases, and you call NSIP as idiopathic NSIP only when collagen disease, hypersensitive pneumonia and drug induced ILD are excluded. Altogether it has got a better prognosis than IPF. It is not a killing disease straight away, even though it is relatively worse for the fibrotic variety. And the age group also, when I said IPF has got an age group of above 60, this one has been described in as young patients as 9-year-old and even in as old patient as 78, but average is between 40 and 50, which is at least 10 years younger than an IPF. Now, what is the predominant feature? The predominant feature is ground glass pattern, and if you look carefully, the exact subpleural region is spared, unlike in IPF. There will be it will be a clear subpleural region, but you get a ground glass. Not only you get the ground glass, it has got a temporal homogeneity, that is the lesions are all of same duration. You get the same appearance on either side of the lung, they are relatively symmetrical too, and as I said earlier, relative subpleural sparing. Honeycombing is very uncommon, and if at all it occurs, it is mild. So, remember that the confident diagnosis is less readily made in HRCT than in IPF. One reason being they are a less serious disease, and the manifestation is only ground glass haziness in the cellular variety, and the fibrotic variety is a bit confusing as it will have mixed appearance. Look at the non-specific interstitial pneumonias. You get bilateral, not necessarily symmetrical, but the lesions have occurred at the same time, that is temporal homogeneity, the word. See this one. This has got little more fibrotic lesions. Then we come to a very important entity called cryptogenic organizing pneumonia. Here again you have to stress significantly about the terminology. See, actually it is the same entity. To begin with, it was coined by different names on two sides of Atlantic. It was in 1983 in Quaternary Journal of Medicine, a case was reported which was termed cryptogenic organizing pneumonia. But New England Journal of Medicine reported something called BOOP, that is bronchiolitis obliterans organizing pneumonia, in 1985. Actually, even now the former term is preferred, or otherwise it is called an idiopathic BOOP, so COP, because it is less confusing. This, when you say organizing pneumonia, etc., where is the organization occurring? That is important, you know. But basically, in this particular disease, organization is occurring within the alveolar ducts and alveoli, with or without organization in the respiratory bronchioles. So, that is why it is called bronchiolitis obliterans organizing pneumonia, but the pattern is organizing pneumonia anyway. So, most of the time we call it COP. So, use of generic term organizing pneumonia is preferred, as most cases are secondary, with modifiers as appropriate. For example, organizing pneumonia in a case of polymyositis, things like that. And when no underlying cause is found, you have to definitely say it is COP, that is cryptogenic organizing pneumonia, or idiopathic BOOP. This is included in idiopathic interstitial pneumonias because of similarities and histologic features of alveolar septal infiltration and idiopathic nature. What are the clinical settings associated with organizing pneumonia pattern? It can occur with pulmonary infection, connective tissue diseases, inflammatory bowel disease, inhalational injury, fumes, etc., hypersensitivity pneumonitis, drug toxicity, aspiration, even radiation therapy and malignancy. So, the radiographic criteria are, I will show the images later, just go through this list in the beginning. Bilateral patchy consolidations, often subpleural in nature, but at times peribronchial or perilobular too. Lung volumes are mostly normal. Rarely you find small or large nodular opacities. You get ground glass opacity associated with septal thickening, which causes the crazy paving. you also get something called the reverse halo sign, that is, instead of the normal halo is the less dense portion is in the periphery, here the otherwise called atoll sign, you get a hazy part in the center with a sharp border, that is called reverse halo sign. Rarely pleural effusions and mediastinal adenopathy, and if they happen to get reticular opacities, they are going to progress to fibrosis. So the chest X-ray, you just identify something like a chronic eosinophilic pneumonia, that is peripheral opacities. See the pattern of CT. You get a geographical pattern. Some parts are quite triangular peripheral opacities. See it more patchy, it's not homogeneous. See exactly what is happening. This is what is happening in cryptogenic organizing pneumonia. The obliteration is occurring in the alveolar duct and alveolar sac, and sometimes it goes to the respiratory bronchiole also. So this is the corresponding CT picture, and this is the corresponding histology picture with the Mason bodies, etc. But if it is a obliterative bronchiolitis, things are different. In the picture which is below, unlike in the above, the abnormal area is the black area, whereas in the upper one, normal area is the black area, the white area is the diseased one. In the obliterative bronchiolitis, what is happening is air trapping occurs, and because of that there is hypoxia, and because of the hypoxia there is vasoconstriction. So that part becomes black. So this is the obliterative bronchiolitis, the pattern is that one. In the last picture, it is the white area which is normal, because the blood is being diverted to those parts because of the obliterative bronchiolitis. So that is why we ask you to not to use the term BOOP at all, if at all possible. It is cryptogenic organizing pneumonia. There are areas of uncertainty in cryptogenic organizing pneumonia still, though some of them have been addressed in recent years, like how frequent are relapses in patients with COP, what is the actual incidence, does spontaneous clinical improvement occur, what are the features those distinguish primary COP from secondary COP, why is this fibroblastic process resolved in some cases, whereas the fibroblastic foci of UIP tend to progressive end stage fibrosis. So at least some patients do improve, in chronic cryptogenic organizing pneumonia, whereas IPF it is a progressive disease. The last important disease is acute interstitial pneumonia, which is an acute disease. That is why we are telling every disease is not chronic. See, it is an organizing form of diffuse alveolar damage, that is DAD, which is indistinguishable from the histological pattern in ARDS. This is something which occurs in ARDS, very similar to that, the radiological counterpart you can say of ARDS. Patients often have a simple prior illness suggestive of a viral infection, which were there for a few days and with constitutional symptoms. Suddenly the patient develops severe exertional dyspnea, and you do an HRCT, you find very specific findings like this: extensive bilateral ground glass opacities, airspace consolidation with air bronchogram and architectural distortion. Consolidation is predominantly basilar and dependent, initially patchy but becomes confluent with time, and it has got no proven treatment. Even within ICU, 50% of them die actually. And most deaths occur between first and 2 months of 1 and 2 months of onset. Even survivors lose a lot of functioning lung tissue, and they go on to chronic progressive interstitial lung disease. If you look at the picture, this will be extensive like this. The pleural effusion is very common, though you find them in this particular case. See, hardly any lung is available for gas exchange. In between, what is ARDS? Is it acute respiratory distress syndrome or adult respiratory distress syndrome? Actually, it is a sequelae to acute lung injury, and the original description in 1967 came as acute respiratory distress in adults. So it was both actually. That is incidental anyway. So there are areas of uncertainties in AIP still, like what is exact incidence, do corticosteroids alter its natural course, what are the mechanisms of lung injury and fibrosis, and what role does AIP play in acute exacerbation in patients with other patterns of interstitial pneumonia. For example, when you speak about acute exacerbation of an IPF, what is happening is essentially a diffuse alveolar damage sets in. Then it appears as though an acute interstitial pneumonia has set in. So, amongst all the diseases of idiopathic interstitial pneumonias, probably this is the most important one, because this sets in suddenly and it has got 50% of mortality. See, even if they recover, you get a lung something like this. Actually, it is not normal. Several parts have actually lost lung tissue, destroyed lung tissue is there, and some fibrosis. The lung function will be very poor in that patient. Now, there are two diseases, or rather three, I should say, which are called smoking related idiopathic interstitial pneumonias. One is respiratory bronchiolitis, and second is called a desquamative interstitial pneumonia. Both occur secondary to smoking. Only thing is respiratory bronchiolitis occur in younger patients, and desquamative interstitial pneumonia occur in slightly older patients and with more pack years of smoking history. Respiratory bronchiolitis itself may not give much HRCT findings, but there is something called RB-ILD, that is respiratory bronchiolitis induced interstitial lung disease. That is what we are talking about. And both these things will show macrophages in alveoli and even pigment, what is called a smoker's pigment. So, both are part of the same spectrum, though different clinically, radiographically and prognostically. So, the clinical, radiological and pathologic features of RB-ILD are, these people are rarely symptomatic, minor small way airway dysfunction, chronic smokers and also heavy young smokers. HRCT shows central lobular nodules, patchy ground glass attenuation and thickening of the walls of central and peripheral airways. Actually, since in general population smokers are quite high, but they do not come to you for evaluation. So, you end up seeing less cases of RB-ILD and DIP, even though in reality it may not be the same. See, occasional respiratory central lobular nodules only, and even a cessation of smoking itself might lead to an improvement. Whereas the same thing, if you go beyond, I am not talking much about RB-ILD because they don't come much under our diagnostic dilemmas. But if you go to DIP, you get this is also affecting smokers, but smokers in 4th or 5th decades of life, and they might progress to respiratory failure, unlike the previous entity which is somewhat self-limiting. And these people have dry coughs for weeks or months, and most of them do improve with cessation of smoking here too, even though they can progress to respiratory failure. And that is why a newer term alveolar macrophage pneumonia is sometimes suggested, because nothing is being desquamated even though the word DIP is still remaining. They are actually intra-alveolar macrophages, and bronchoalveolar lavage might show increased macrophages with smoker's pigment. Here HRCT shows a lower zone predominance. In RB-ILD there were nodules in the upper zones. Here it is basically in lower zones with cystic spaces due to alveolar ducts and sometimes limited honeycombing to unexplained cystic spaces, as you can see. There are areas of uncertainty in DIP, that is the whether it has got any relationship to pulmonary Langerhans cell histiocytosis, or is there a role for corticosteroids, or why some of them progress to fibrosis and not all of them. And the last entity is really rare, which is called lymphoid interstitial pneumonia. These were thought to develop to lymphomas and were considered pre-neoplastic, but no more now. It is not part of a lymphomatous process, but immunohistochemistry and molecular analysis is able to differentiate between this neoplastic and reactive varieties. Incidence is quite low, onset is slow, and it is more common in women. The dominant CT finding is ground glass opacification with curious perivascular cysts or honeycombing. It is not very common. There are areas of uncertainty in LIP also. So, at this point we are stopping our discussion on idiopathic interstitial pneumonias and diffuse parenchymal lung disease. The main points which I wanted to stress were: one, role of HRCT in differentiating these diseases. First, differentiating all other diseases from idiopathic interstitial pneumonias, then differentiating idiopathic pulmonary fibrosis from other diseases. But as I told you earlier, between 2000 and 2013, more revisions came in the topic with incorporation of more countries. For example, Asia and Latin America also was involved, and at least one entity has been totally newly added, which is called the idiopathic pleuroparenchymal fibroelastosis, and some rearrangement of the classification has happened, and also more clarity exists now regarding diagnosis of idiopathic pulmonary fibrosis and NSIP. I am sure we can discuss the radiological appearances with hands-on viewing of cases on a later date. Thank you.